So I'm delighted you're here. I love presenting on topics, so I'll just give you a little overview of what's going to happen tonight. First of all, for those of you that haven't been here before, if you do need to use a restroom, straight across the hall into the other office space to the right is a restroom, and then down this hall, the second door is a restroom. So if anybody needs to use that, by all means. The format of the workshop is this. I'll give a bit of introduction of myself in the clinic, why I'm here. I'd love to hear a little bit about you so that I'm sure to be able to cover some material that will be valuable to you. I'll present some information on the different contributing factors that can occur for low back pain and sciatica. And we'll talk a bit about what some solutions are for common causes. And we will have a chance to do what I call the 5-minute miracle, and that's a chance to see what trial treatment might be to give you an idea of the approach that we use here. And then we'll let you know about next best steps. Fair enough? All right, so I like questions, so you can ask questions as we go along. I'm happy to go through the material, so either way. First of all, this is how to relieve back pain naturally without medication, drugs, or surgery. We help people achieve greater mobility and strength for their active life without injections, medications, or surgery, even when nothing else has worked. That's been our mission since we opened a little over 5 years ago. A little bit about myself. I've been a physical therapist of over 30 years, and all of those have been practiced in the Oshkosh area. For the most part, I had the opportunity to train as a fellow in physical therapy, which means that I was able to understand some of the best research and clinical applications of relieving pain from head to toe. And that's what kind of prompted my interest in delving deeper into some of these areas. Dr. Rebecca is also on our team. She's a doctor of physical therapy. She's had over 10 years of clinical experience. She has some advanced training in Gary Gray's Science of Applied Movement. Patients really enjoy her. She was the physical therapist in Wisconsin of the year in 2019, and it's easy to know why. Patients like working with her as well. She's been in the Oshkosh, Indiana area for all the while. Dr. Jessica is a graduate of Marquette University. She's the newest doctor of physical therapy on our team. She's certified in vestibular, balance, and dry needling, and she is doing a great job here. We have 2 physical therapist assistants. Gina is, what was that?
She looks really young.
Yes. Agreed. Gina is a physical therapist assistant who's been with us over a year, and she's specially trained in pain relief and sports recovery massage, certified spine specialist, certified upper extremity specialist. She's doing a great job for us here. Courtney's the newest physical therapist assistant here, newest clinician. She's got over 6 years of experience. She comes to us with lots of experience working with older adults. She's specially trained in pain relief and sports recovery massage, certified spine specialist, certified upper and lower body specialist. So just let you know that we value training here and we want the best for our clients. So that's a little bit about the team here. Lori Shates. So Lori is an occupational therapist who I've known for a long time. She was the first call I made when I decided to open up a clinic. She's a fierce patient advocate, very skilled in edema and lymphedema. And she does trainings for other folks with that. She's been around for, like I say, over 30 years. So it's a little bit about the clinical team. Robin's been with us 9 months now, is that right?
May.
8, 9
Wherever
months?
May, yeah, wherever May shakes out, somewhere in there.
Right.
Yeah.
Somewhere in there.
Robin comes to us. She worked in, I forget the title that she had for a number of years in healthcare.
CT technologist.
CT technologist. So she is helping us with the patient experience, helping things run. She'll be managing some of our wellness programming coming up, so we're delighted she's here as well. So why Physical Achievement Center was started, the bottom line is I became frankly ticked off that people weren't being offered all their options when it came to pain conditions, such as shoulder pain, neck pain, headaches, lower back pain, knee pain. There is a strong bias towards medications, drugs, and surgery. Not much discussion in primary care offices or specialist office for conservative intervention. And the research continues to mount that there is oftentimes not beneficial effects of many of the type of surgeries, and people are exposing themselves to unnecessary risks and costs and not being aware of all of their options when it comes to conditions. So I felt I needed to start an independent private practice so that I can have conversations about all the range of options, because what's important to me is that people be educated so that they can be part of the decision-making team. Great decision-making team is when you have the patient at the center who's educated about options. You have providers who maybe support the options that patient chooses, and then hopefully some research that supports those outcomes. When those three line up, when you have patient preference, provider who's willing to provide that, and supporting research, the mixture of that we call hitting the bullseye when it comes to what's called evidence-based practice. Outcomes usually are very positive. So we can't make good healthcare decisions as consumers if we don't know all our options. So that's essentially why we started, right? So we want to make people make better healthcare decisions with a bias towards natural healing without medications, pricey injections, scheduled for surgery. This is an incomplete picture of our team. We'll get our new picture uploaded soon. And we want to make sure we're a resource for people who are unsure, stuck, or not sure what all their options are. And we're not going to disrespect folks by saying silly things like, what do you expect at your age? Or you'll just have to live with it, right? I don't think our clinicians and staff will last real long here if that's their perspective when it comes to patients. All right, so we'll get right into some content here. Can't talk about low back pain without talking about sciatic nerve. What the heck is a sciatic nerve? The sciatic nerve is the longest nerve in the body. It comes from the back, runs down the back of the butt, and then splits into two past the knee. When there's an irritation in the back, or maybe in the muscles around the hip, sometimes even in the hip joint or some other structures, you can get pain that refers down to the back, down the back of the leg, right? So sciatica would be referring to irritation of that nerve. Oftentimes, there's multiple causes of that. We'll get into, there's misperceptions about pain down the leg. We'll talk about that as well. When it is truly involved, when there's a true irritation of that nerve or a true pinching of that nerve, you'll get weakness potentially, get pain down the leg, sometimes heaviness in the leg, pins and needles, that sort of thing, right? We differentiate whether or not it's referred pain, in other words, backs. Different structures in the back can refer pain down the leg, meaning there's an irritation here, but it's just felt down the leg, versus is the nerve actually interrupted? In other words, if the reflexes are changed in the ankle or foot, if the muscle or the sensation, ability to feel sharp, all that sort of thing is involved, helps us decide whether or not, what type of problem it is, what kind of solutions and options are available for further assessment. That's the sciatic nerve. So, the mistakes that back pain and sciatica sufferers make is to do nothing. Talk about like this interval of onset of symptoms gets aggravated. We've got people here who carry on despite difficulty, right? Everybody's looking for an opportunity maybe to make some improvement. I'm always of the opinion that people can make improvements, right? It's a personal belief of mine, right? You don't end up being a doctor of physical therapy without being a perpetual optimist. But if you don't do anything, you're not going to get any help. Nothing changes, right? The longer you have had pain, the longer you can take to recover, although it doesn't mean that just because you've had it for a while you can't get better. It just means that once pain's been around for a while and you make some adaptive changes to it, you know, one part might kind of throw off another part, so there's just more to sort through. Next biggest mistake that people can make is to mask the pain with over-the-counter NSAIDs, non-steroidal anti-inflammatories. So the stuff that we can get off the shelf with creams, lotions, potions, that sort of thing, especially muscle relaxants and opioids. To get through a day, oftentimes people do slather on something or put a brace on or something like that to get some relief, to get through the day. That may be true, but the challenge is when you're doing those sort of things, you're not looking for further solutions and improvements to your issues. Muscle relaxants present some problems, particularly because over time they're not as effective, they're a bit mood altering, and I was in healthcare during the time when opioids were promised to be safe and effective for long-term pain relief, and they're proving to be neither of those, regrettably.
I think.
Right. Yeah. It's. I had to. One of the things you talk about the inspiration to start a practice. I had an opportunity to meet 3 men who were about my age, blue collar types, and within a short period of time, within a week, I think I met all 3 of them. I did a short stint of working with folks in the prison actually, and I'm a doctor of physical therapy. They're not trying to impress me. I don't have anything to do with their stay there other than manage them medically, and they just had simple orthopedic issues. Surgery was one, injury on another, and they happen to be 3 blue collar guys who are the part of the statistics that got addicted to the opioids. Then they pulled the opioids, if you will, off the market, and then they still have the addiction, right? So that led to some horrific events, and they pretty much lost everything in their life, right?
Is it okay if I say something about
Sure.
the NSAIDs?
Sure. About the NSAIDs?
About the NSAIDs.
Sure.
My cousin could not make it to our wedding, like Joanne and I, because he'd been taking so many of the Aleve or the other one that starts with an A. Advil. So he'd been taking so much of me, his liver went away. So he couldn't, it was at that time he couldn't be with us for the wedding, but his wife gave up half of her liver, and now he's okay. But he stays away from the NSAIDs.
Sure.
We don't take them for 23 years. We've been that long in natural health, so this month.
Yeah, so they carry real risk of real side effects. I have the opinion, and this is based really on nothing, but I think with the evidence that has accumulated over the last 15, 20 years, that I don't even think if over-the-counter NSAIDs were offered on the market, I don't think the FDA would pass them right now, given what we know about them now. It's just a matter of people have access to them. They're not going to take them away because many people want to use them, right? Cardiovascular risks, liver, kidney, and I think there's evidence of cognitive risks too to the central nervous system. This is big, number 3, ignoring. I have the term holistic, like it really should be comprehensive treatment. We'll talk about what comprehensive treatment looks like, at least how we view that here. Looking for a single solution to their problem, right? So, people can maybe think, oh, you know what, maybe I can get that injected, and that might be helpful for pain relief. But if you don't change anything that's brought about that pain condition, the pain relief from that injection is going to be pretty short-lived. Right? Because nothing else has changed that brought on that imbalance to create that pain problem, right? Sometimes people look at, hey, I'll just maybe exercise, or I'll just get, a massage or that sort of thing. But so we look at it from comprehensive treatment, holistic treatment. But there's a number of different ways we can approach this, and we'll talk about that a little bit later on. And that's kind of piggybacking on relying exclusively on surgery injections for relief. You guys are looking for other options. That's what we do here. So when we take a look at, we start to build clues in terms of what kind of help can be afforded to people, right? And certainly during the presentation, everybody needs to sit, stand, move, shift, by all means do so. But as we take a look at talking with somebody about their condition, we can start to get some clues about what might be going on in terms of how their symptoms develop. Standing versus sitting, walking, bending. Is it relieved with lying down? Is it relieved with certain movements? You can start to build some clues. there's an expression, if the pain is reproducible, in other words, if we can turn symptoms on in a physical examination, and you'll see this perhaps tonight during the 5-minute miracle, then there's a chance that we can reduce the pain because that's a pain of a mechanical origin. There could be some improvement to that condition. 3 ways to handle pain. We talked about this. Another way to discuss it. Ignore it. Not do anything about it. That's one way. And just kind of get through. Alter it. Masking it with pain pills, over the counters, slather something on it, put a brace on it.
Word, masking.
Masking it, right? Not get into the root cause or handle it. Properly handle it. Attempt to get to some root causes and move beyond that. So, we're going to talk about common causes of lower back pain and sciatica. Some things that you probably never have heard before. We'll talk about some well-known findings of x-rays and imagery that should be considered when people do get x-rays and MRIs. And we'll talk about some less commonly understood causes for back pain and lower leg pain. So we'll talk a little bit about first, I think we'll just start with this basic anatomy. I think that's really helpful, right? So this is me looking forward, plastic spinal model. So lower back sits upon the sacrum with the bony pelvis underneath. We've got 2 hip joints that operate underneath that. And there's a relationship, the hips to the lower back in a couple of ways. I'll explain more about that in a little bit. The vertebrae are stacked here. Generally there's 5 lower back vertebrae, 12 thoracic vertebrae. Each of those vertebrae have actually 3 joints between them. People know about the disc joint between them. We hear a lot about that. That got a lot of press. In fact, when I first got out of physical therapy school back in 1990, that's all we talked about. Everybody's got a back problem. It's either degenerative disc disease or it's a bulging disc. But the disc is the spacers that are between the vertebrae that there are times when those discs change in shape. They're non-ideal. This one shows what we would call a hot disc, right? So there are times when the disc is not where it should be and can be a problem. And that becomes an issue by interfering with this yellow structure here, which is representative of the nerve. So you could think of the spinal column, if you've got the brain up here, central nervous system. The central nervous system is sending signals down through the spinal cord. So if we open this up, it'll be the clear tube here. Sending signals down, and that inside of that spine are also signals that are coming up from the body. On these side projections are like the on and off ramps of Interstate 41. So there's nerve fibers reporting messages back to the spinal cord, and up to the brain. There's nerve fibers coming away from the spinal cord to the body parts. You can think of this as the off and on ramps. There's a junction between the lower spine and the upper spine. So this is the thoracic spine, the spine that's attached to ribs. We're going to talk about that junction there. And then there's a hip muscle. It's called the hip flexor. It's connected to your leg. It's responsible for bringing your knee up and helping you stay stable when you lean back. That's kind of runs from the hip area, back of the pelvis, to the lower back. And that can become associated with the lower back because those fibers of that muscle connect directly to that hip. So we'll talk about a number of different things, ranging from spinal stenosis. We'll define what stenosis means and how that relates to the spine. Talk a little bit about discs. And talk a little bit about muscle balance and the hip joints. Just having a hard time with my voice here today. Do we have anything that would help?
Want some tea?
Sure. No caffeine. We're talking about difficulty sleeping lately with
Caffeine
full
too late.
mood.
Yeah, when we were like 20 years old, we could get away with drinking coffee all day long until 9 o'clock, right?
Yep.
Still pass out while you were asleep.
Right.
Not that way anymore.
So the first thing we're going to talk about is herniated disc symptoms. Herniated discs are the space in between the vertebrae. The outer portion is a firm tissue, the inner portion is a liquid tissue. And one of the things that happen over time is those discs change. They get less fluidy, right? And we actually lose vertical height. That is a natural age-related process. If we take, I will get to that a little bit later, but when the discs are having some of their material that's out into that space, they can cause some irritation of those nerves. Typical disc symptoms are thought to be prevalent with increased symptoms with forward bending, twisting, coughing or sneezing. It can cause sciatic symptoms that run down the leg, oftentimes past the knee, even to the ankle and foot. Typically, herniated disc sufferers, we tend to think of them as younger than 40 years old or in about that area. But there's really good evidence that it's fairly common in older adults. How significant it is, we'll talk about that as well. If there's enough disc material into that space, thank you so much, appreciate it. We'll start with some of that. If there's some disc material that's causing some irritation of that nerve, that it may actually cause weakness in the ankle and foot muscles. And that's cause for concern if that happens. We test reflexes, we test strength, we test the ability to sense in the lower leg. If those are all intact, it's probably not disc bulge that's problematic. Oftentimes people with disc problems can relieve their symptoms with backward bending or changing positions, and then we use that to help actually treat that. There was a one of my occupational therapy colleagues. She went to get some a consultation. She was in her mid-40s, I think. She certainly had a disc problem. She went to one of her friends who worked for a neurospinal place, does neurosurgery, and they have an expression at the neurospinal facility that says, "Quick, let's schedule surgery before things change." Which they kind of laugh about it. What that means is, hey, you know what? For many individuals, if you don't do anything, those disc problems go away on their own because the body's always changing. That's used in humor there, but I always don't find it really funny because that just means that perhaps we're exposing people to unnecessary risks with some surgeries for a wide variety of reasons. Research has shown that as long as there's not changes in vital bodily functions, bowel, bladder, muscles, that disc problems kind of get better on their own. So I want to draw your attention to arthritis or stenosis. And does anybody know what the term stenosis means?
Is that narrowing?
Narrowing, right? Kind of narrowing of different structures, right? So stenosis in this instance would be either central stenosis, which is that central canal between the vertebrae. And I'm going to pass this around, you guys can play with this, or it could be lateral stenosis. It means a narrowing of that space. Well, I talked about 3 joint structures between each vertebrae. We talked about the disc joint. I left you hanging. I didn't talk about these facet joints. But if we kind of move this spine front to back, you'll see these other surfaces that contact. Those are each what we call synovial joints. Each of those joints has a joint capsule, and they have joint receptors and that sort of thing. So there's actually 3 joints, the disc joint and these paired facet joints. Well, you can envision if you get some arthritis at the edges of the vertebral body, or if you get arthritis in and around those facet joints, you might get a narrowing of some of those spaces. That's what's called stenosis.
Okay, just what is arthritis? Is it, I mean, you said it's around the joints, so is it like it's not a calcification, or is it? Or what is it?
So arthritis is an alteration in the joints brought about by an inflammatory process. the joints will change, the connective tissue will change, the underlying bone tissue can change. So the joint region has this change that you can observe on X-ray, CT scan, and MRI.
Okay, so it's a change, but it's not like a calcification or something like that.
Bones are made up in part of calcium.
Yeah,
So on X-ray, you'll see the effects of the joint changes based on what you see from the calcium deposits. And there's decisions made about, is that abnormal, is that not normal? Or inflammation is itis, right? So it's a change in the joint that you can see with different clinical examinations. We're going to talk a fair amount about it, but good question. I mean, it's not an easy
because I don't understand exactly what it is. I mean, like, if you break a bone,
Yep.
it calcifies.
I'll
But
pass this around.
arthritis, I don't get an answer as to exactly, I mean, I don't know.
So classically, we thought of two types of arthritis. One was kind of the rheumatoid arthritis that happens because of abnormal inflammatory response in the body that tends to affect, you see people with hands and feet that get all gnarled up, right? That was understood to be one end of the spectrum of arthritis. Another type of arthritis was the large joints of the body, knees, hips, ankles, shoulders, and spine, thought to be quote-unquote wear and tear arthritis. Our understanding of that is a couple things. Number one, there's not as much exclusivity, but there's lots of mix, if you will, or gradations. And in osteoarthritis, it's not necessarily wear and tear, it's changes in the joint structure that likely have an inflammatory component too.
Like from an accident is a possibility.
Trauma, poor posture, dietary habits, overuse, underuse, that sort of thing can all bring it on. Genetics certainly plays a role, so it's kind of not a very well-defined answer. I don't know if am I struggling with this, or is there a more succinct answer that I can give?
No, I know what you're saying. It's an inflammatory process change that affects the joints, basically. So it may appear to be calcium, like he's saying, just because the bones have calcium in them. So that's how imaging is going to make them appear on there. But
Well, I think it's important. It's important because we're going to talk about that very shortly here. So it's not as clear and tight as we'd like it to be. Is the bottom line. So here's a common features. Like typically, someone over the age of 50, 55, if they have lower back pain, worse with standing and walking, they need to lean on something like a shopping cart to get better. The distance of walking. I mean, we had even a little bit older group this morning, and there was one woman who said, "Oh, I walk, what was it, 4 to 5 miles a day, or 5 to 6 miles a day," and you could just see a couple of people that are like, "Oh my goodness, I'd love to walk that far," right? But the inability to walk distances, the inability to stand upright for a long period of time, that tends to kind of go along with some of this kind of stenosis issue potentially, and is real common with arthritis. So generally better with sitting, worse with standing. And that's classically thought to be, actually back in the day, the treatment was, well, don't bend backwards, just do some called Williams flexion exercises. In your nursing career, you remember hearing that, but just relieve those symptoms by bending forward. Well, that's all fine and good. You can relieve symptoms by bending forward, but how many people live their lives like this? Like a lot of people live their lives by cooking and cleaning and standing and talking and walking and hopefully playing some pickleball and gardening, right? So, people need to get to an upright stance, right? So, strategies to treat that have evolved, but people aren't oftentimes offered options for that. Muscle instability. This is interesting. So, these are two images of some muscles of the spine. These are the deep postural muscles, called your erector spinae. The name's not important. Just know that those muscles are deep and close to the bone. Those muscles are responsible for holding upright posture when I'm not trying to think about it. These muscles are capable of light contractions over a long period of time. Muscles that are illustrated on the top diagram are the muscles you'd see on a well-developed bodybuilder reflexes, right? And those muscles are capable of lots of power, but they're not active much of the time until there's volitional pushing, pulling, that sort of thing. Structurally, the two muscles are different. These muscles are capable of contraction for a long period of time, so these have more oxygenation in them, so that they can have long, sustained contractions.
They have what in?
More oxygen in them,
Oh.
more red blood cells, so they're the red meat, if you will, if you think of chicken. The muscles of movement are more the power muscles. They're capable of a lot of force, don't have a lot of blood storage, so they're the white meat. So, when there's a problem in the spine or body parts, oftentimes these these muscle functions get reversed. You just get mismatched. Maybe those muscles of posture, they forget to work properly, and maybe they get shut off. Muscles of movement oftentimes get turned on, and they're sustained contraction for a long period of time when they shouldn't be. That's called a muscular instability or muscular imbalance. People get a painful catch, maybe when they're rising to standing, when they bend forward and then come back up. And we can see these sort of things as people move and function. These sort of things aren't necessarily showing up on X-ray, CT scans, or MRIs because it's how the body is in function, right? MRIs and CT scans tend to be just looking at people in a static position. You can only detect this with proper, what I say, history or listening to the patient and their symptoms, and then doing a proper examination. It isn't as common, but that is a condition that happens. Nerve pain and irritation. So if you think about a time when you might have been kind of stressed about something on your mind mentally, or maybe not a lot of good sleep, and someone maybe was kind of joking with you or said something to you, and maybe you kind of blew up. And later on, you had to go back and apologize, say, look, I'm sorry I lost my cool, I had lots on my mind. That's happened to a few people, maybe. Your hair triggered at that point, like one little perturbation, you're going to go off. Well, nerves can get hair triggered too. Ordinarily, they're just functioning a little bit, reporting some signals to the central nervous system in the presence of pain that's been around a long time, or the presence of inflammation, or maybe lack of sleep. Those nerve fibers get jacked up, and it takes very little for them to become agitated. That's what's meant by nerve pain and irritation. When pain's been around longer than 3 to 6 months, it's called chronic pain, just how long it's been around, and those nerves can become overly sensitive. This is pain that doesn't seem to go away, or very little activity brings about a high level of pain, and it takes a long time for the pain to calm down. Nerve pain and irritation is not generally seen on X-ray, CT scans, and MRIs because it's not looked for. It's one of the features that can happen for individuals who have pain issues. And it can be identified, and there can be strategies to treat that in and of itself.
Can pain cause, because of the nerve, whatever, cause nausea? It seems like my body responds to pain and nervousness with nausea.
Absolutely.
What do you do to prevent that? My daughter says, don't get nervous.
I think there's different strategies that you can use to calm that nervous system down. The range of possibilities are from some of the hands-on work that we do to exercise, to improving sleep patterns, maybe improving diet, supplementation. There's a number of things to do, but you know, anxiety, anxiousness, nauseousness, depression, and persistent pain, they kind of go hand in hand. They kind of feed on each other. So whatever way you can intervene can be helpful. So I'm not being real specific about that, right? But good question. All right. So, it was understanding of the research like this that led to the foundation of me understanding that we need to be doing something different in terms of our conversations with patients. Because life is life getting simpler as time goes on? Right?
In some ways, but not in all ways.
No, I mean, things seem to be more complex, right? So we, in medicine, we try to identify, hey, a pathoanatomical answer to everybody's problems. Patho means bad, anatomy means anatomy, right? We try to find bad anatomy and blame everybody's problems on that, right? What we find is there was research that came out that took a look at scans of individuals who don't have any pain. So these individuals might be getting examinations for a whole wide range of things. Maybe they're getting screened for cancer or who knows what, right? But can be a whole large catalog of individuals in their 20s, 40s, 60s, 80s, and above. And we can take a look at different slices and different views to determine if they have other stuff going on that they didn't come in for the scans. Are you with me? All right. So what they did is, and this research project's been replicated, is radiologists, the medical experts who read imagery, designed these studies, and they just looked at images of individuals in different age groups and decided, hey, we're going to see how many people who don't have any pain have positive findings, and we'll highlight two of them. One is disc degeneration, and that's basically thinning of the vertebrae between each, and the other is disc bulge, so think of the blue and green. This chart is laid out so that these are findings of individuals in their 20s across this way, and people in their 40s, 60s, and 80s. These are the percentages of individuals who have these findings who don't have any pain on scans: 0, 25%, 50%, 75%, 100%. So we just look at people in their 20s. So think of somebody you know in your 20s, or when you were back in your 20s. More than 25% of individuals have disc degeneration and positive disc bulge who don't have any problems. They're walking around, they're fine. They're going to the gym, playing, working, all that kind of stuff. In the 40s, that's above 50%. In the 60s, that's approaching and above 75%. And congratulations if you're on your planet in your 9th decade, pretty damn near everybody's got that, right? So, that's really interesting. So if you have a condition, you've got some pain or issue, you show up and they say, hey, let's do a scan. And then if they find something like this on the scan, oh, that's it. Well, how do you know? Because that's common in individuals that don't have any pain, right? This is rarely, if ever, discussed with patients when it comes time for results of the examination, because if we find what we're looking for, they're like, okay, check, that's it. This is really significant. Whether or not these things for an individual is in pain is significant really depends upon making sure that we understand what that person presents with, taking a really good history, doing a really good physical examination, balanced with the imagery. But the imagery oftentimes is the only thing that's really considered. Does that make sense? I had one patient who told me once, she had a scan, and her nurse practitioner sent her a nice little, I think it was an email on their system, and they said, well, Mary, that's not her real name, you have what we would consider normal age-related changes in your spine that is normal for someone of your age. Do what you can to manage your symptoms, stay active, and consider non-drug, non-surgical ways to control your pain. I've only heard of that once, coming from a medical provider, which is delightful because it was actual honest communication about potential findings on MRI. I'm sure that person was also examined well by that nurse practitioner, and a balanced discussion was given. This is important, I think, to start to arm ourselves with understanding of what some of the limits of the scans are. I love MRIs, CT scans, they're beautiful. They see very fine detail. The challenge is they see things at such a fine detail that they're too sensitive. Like, body's not, parts inside aren't perfect, right? So if you see it at really fine detail, that can be really good if you're looking for something that's pertinent, but oftentimes it sees too much, it's overly sensitive. So, in other words, everybody in their 8th, 9th decade is going to have with a term called degenerative disc disease. It's an awful term, just means that over time your spine changes. We wouldn't call somebody who's got gray hair, they have follicular degenerative disease, or someone who has wrinkles, right? Skin degenerative disease. It's just normal age-related changes. Wrinkles on the inside for many of these things. All right, we're going to talk about a couple other things. I talked a little about muscle balance. We talked a little about the hip relationships. Tight hip joints and that are inflamed can contribute to lower back pain. You see the muscular attachment here. So this is somewhere from the front view, the lowest lower back vertebrae, the rim of the pelvis, and the two paired hips. Those hip joints are right here by the front pockets. There's a muscle that runs from the hip joint up here. So tightness or imbalance in that muscle can certainly pull and change things through the spine. It has a direct connection to the spine. Stiffness in the hip joint can also contribute to lower back pain. They're fairly close to each other. If you look at the spine here, this is hip joint, this is lower back. They're pretty darn near close to each other. So hip specialists and spine specialists, if you get them talking, maybe get them a drink or two, loosen them up a little bit, they'll start to say, hey, look, sometimes I don't always know if their pain that's in the lower back or side of the hip or front of the hip, I don't always know 100% if it's the hip or the lower back. What we do here generally is if there's a issue with the hip or issue with the lower back, we treat both. Just because they work together, right? And you might see that in the assessment today that I do, how we assess the hips. So taking a look at the hips as it relates to the lower back, we talked about the lower back conundrum. If someone's got a back issue, pain in here, and people are only looking for solutions in the back, not looking at the hips with a physical examination, they're going to miss the point and it won't show up on X-ray, CT scan, or MRI. Proper examination and history will tell you that. Certainly how people move, sit to stand, stairs, squatting, that sort of thing. Can tell us a lot about the structure and the wellness of the hips. This is one of my biggest surprises. Found out about this about 7 years ago. And there's a number of patients who I treat, like they don't have horrible flexibility, like the muscles are pretty good, like you do some things that kind of help, but they keep getting this pain that's kind of in their lower back of the pelvis. Some of it might even wrap around the front of it. This is just kind of a picture of someone's back. There's a nerve that comes from the area below the brow line where the lower back meets the lumbar vertebrae, and that area is right here. There's a nerve that runs, you'll see this nerve here, it runs along the side of the flank, down in the butt, can even come towards the front of the hip, maybe even to the genital area, the front of the groin. When this nerve is irritated, and it can be irritated just from stiffness in that area or a bit of inflammation, you can get a referred pattern into that area. The pain could be here or here, but the irritation is up here. That's a condition called Main syndrome. Physician by the name of Main first coined that term, I think it was the early part of last century. Medical types will inject that joint to see if the pain calms down. If it is, check, good. We can mobilize or manipulate that joint, stretch it out, and if there's a change in symptoms, and this diminishes quite, and oftentimes quite vigorously, it can be a clear indication that there's an issue in that upper spine area as well. Obviously, if you're not looking for solutions up there, you're not going to see it on X-ray, CT scan, or MRI. It can only be detected with proper examination and history. Talked about a couple of common issues that are, or several common issues that are possible for people with lower back pain, sciatica. It's possible to have more than one issue. What do you think?
Yeah.
Yeah.
Typically, yeah, right? So if back in the day I was pretty ambitious about trying to seek out the best treatments for my patients with back pain, for instance, and I spent a lot of time and money, I'd go learn a technique, I'd come back to the clinic, and apply that real enthusiastically that Monday morning through that week for a couple of weeks. And a third of my patients would give me high fives. That was great, feels awesome. A third of my patients would say, oh, it feels a little bit better. A third of my patients, I love this, would say something like, it's subtle. right? Which is Wisconsin nice for, it didn't really
It didn't.
matter, right? Bless their hearts, right? That's awesome. No matter which type of approach, even when approaches were vastly different, I had about that proportionality of improvement, right? It wasn't until we started thinking about, and I started thinking about, hey, look, maybe different approaches work differently for different people based upon how they present with their age, clinical assessment, and maybe we can think of not back pain as one thing, but potentially a number of things and start to individualize what's likely going on with them and start to work through, hey, what's the most likely thing going on with this person? And when seen through the lens of that, when we individualize the assessment, solutions are much easier to come by and people tend to get better relief. You don't sit on your bum when you're on.
In winter, yeah.
Winter you do, okay.
Because I'm on call 24/7, so.
Got it, okay, fair enough. So is it problematic for you to stand
For a few minutes now.
for a few minutes? No, okay. Come forward here, I'm gonna move and create some space here. So you can stand actually right as you are. Actually, if you don't mind, just walk to that door and back. I'm just gonna get a sense of his walk and movement. So as I watch him move, he seems to struggle as he puts weight on his left leg.
It's getting my nerves kicking my butt at home.
You what?
The nerves kicking my butt at home.
Show me where.
Starts about here, and it's about right here.
Got it. While you were sitting or when you came up to standing?
Sitting, I was getting irritated. Standing usually, or walking usually, mild it down a little bit,
Feels better to move about a little bit?
but then that starts hurting.
Got
If I go too much.
it. Okay.
There's never a good petting.
Fair enough. If you don't mind, I'm going to turn and face the TV here. I'm going to ask you to do some movements, but I don't want you to move beyond what is reasonable. I just want you to see what comes easy before onset of any symptoms. Move the cord this way. Hate to interfere with a young man who's doing his work out there, but all right. So if you would please, I'm going to have you just go ahead and bend forward to the extent that you can, reaching your fingers towards the floor, and then come back up. Okay, so I heard a groan there. That probably didn't feel great on the return, or going down, or both.
Both.
Okay. So now think about what he does. He's got to bend and move and twist. Like if he just can't, that's going to make for a long day if he can't move really well in that basic movement. What I'd like you to do now is I'm going to have you, you're going to stay standing, but you're going to slide your right hand down the side of your leg to the extent that you can. And come back. Does that bother someone at all?
Not too bad. On the up it does, but on the down it feels good.
I'm going to have you do that one more time. We can kind of see, it's got decent mobility there, more than I would expect. I'm going to predict it's not going to be so good on this side. Go ahead and do the same thing on this side. And come back up. How was that?
About the same the first go around on the other side.
Okay. So I'm going to have you do a movement where you're going to put your hands back here and you're going to press your hips forward and do a little bit of backward bending. What's that like?
Painful.
Okay.
Tight. And back is tight today.
So all the movements that you've done so far, which one or two would you say is most bothersome?
Most bothersome.
In terms of
Probably
this
bending
backward
back.
bending, right? So think about backward bending, right? A number of you here struggle with backward bending. So I'm going to have you sit on the table and kick off your shoes. That's an issue because if you can't backward bend, then coming to standing just upright is stiff and sore because you might be at the end range of your tolerance. I'll test some things out further. If you don't mind lying your back with your head here. I'm going to raise the table up. This table's got a little bit of a incline there. Good. All right, so the first thing I'm going to do with Justin is I want to see how mobile his hips are. How are you doing here lying down?
Fine.
Any pain down the leg? None?
No.
Compared to sitting, that's relief compared to standing.
Yeah, it feels pretty good at the moment.
Great. So I'm not gonna do anything tricky, sunny, tricky, sunny, or funny.
That's what takes fast.
Right. So we're just gonna check out hip mobility here. So ideally, these are pretty loose pants here. Ideally, that knee would come up darn near his chest. Not much doing there. Like, that is not optimal. Little clink on the way down. Is that painful at all?
No,
No.
no, that's one that nobody can figure out what it comes from.
We're gonna check out the other side. The other side certainly goes up a bit more, but he's not overly comfortable with that. I'm gonna test some in and out. Like, I'm not real happy about his mobility in this hip. He should be much more nimble in that, especially for the type of activities he's accustomed to doing. Any bother in the back at this moment?
Mm-mm.
Hips, legs? I'm gonna test something else. I'm gonna stretch out his sciatic nerve and see if there's any signs of any distress with that. I'm gonna move real slow. I'm just gonna do a little simple movement here. Any bother anywhere in your back, right leg, left leg?
Yeah.
Where at?
Behind the knee,
Okay.
about
that-
right here.
And let your toes down. How about now?
Still hurts.
How about now?
That's good there.
Lift your head, look at your knee. What about now?
Painful.
Okay. Keep your head down. How about now?
Oh.
His sciatic nerve is actually stuck. Doesn't move real well. So he's got some irritation in along that, so this is really interesting. Does that calm down a little bit?
Pretty much, yeah.
So think about him doing his heating, cooling, and crawling around. That's going to be an uncomfortable experience, I think, until some of this stuff calms down. We're just take a look at this side. What do you notice here?
Just like a good stretch. It's all about right there.
Then what?
Right here.
Okay. How about now?
Same.
No.
Now it's in the back.
Okay. No.
Still in the back.
All right. Let that calm down a little bit. So, some muscular tightness in around the hips, maybe some joint tightness around the hips. That nerve glide doesn't, there's plenty here to think about and work with. I'm going to see what it's like to assess his lower back here. Do you ever lie on your stomach?
Mm-hmm.
So I'm going to grab a big towel. Bring a little towel here for protecting the knee anchor, Thank you. So what's the coolest thing that you've ever found looking for metal and gold?
About a 9,400-year-old copper spear point from the old copper culture days here in Wisconsin. Found it actually in Appleton.
That's cool. 9,400 years?
Estimated, yeah. Then I have another one that's about 5,000 some years old. Tell by the shape how they hammered them out.
That's awesome.
Yeah.
That's cool. You're a historian. That's cool. Line your front side if you would, please. Lift your feet if you would, please. How is this for you?
Fine.
What I'm going to do is I'm going to apply a little bit of pressure to different vertebrae areas, about like this. We're just looking for any that might be stiff or sensitive, or other areas that might be really comfortable to apply some pressure on. Fair enough?
Mm-hmm.
As you're lying here, any pain or discomfort?
No.
Pretty comfortable position?
Yep.
Probably wishes he could do his work from this position, right? So, this is the top of the sacrum. I'm just going to apply a little bit of pressure to that. Any bother there?
Nope.
Apply a little pressure just above that. presumably over his lowest lower back vertebrae. Any bother there?
No.
About here?
A little pressure, that's all I feel.
Here?
Nope.
Here?
Nope.
So flexibility is increasing. How about here?
Nope.
Here?
Nope.
Getting above that area for the main syndrome area. So you had some stiffness in that lower back, a little bit of bother. How about it out to the side? Anything in here?
A little sharp pain.
Similar to what you get when your back bothers you? Is that
Mm,
familiar to you?
no.
No, different? How about
More
here?
of a stabbing. Not a stabbing pain, but more of a stab.
Right now at this
Like
point?
each time you push, it's not like a normal.
What I'm doing is applying a little bit of pressure to that joint, just asking, hey, is there some flexibility in that joint? Does that area have some nervous system sensitivity? What areas are maybe needing some attention? How about here?
It's fine.
We'll do a little bit on the other side. How about it through here?
Fine.
Here? No bother?
The last spot, about two or three vertebrae up, I can feel the back kind of twist.
Anything here?
No.
Here?
No.
So mostly on his left side, lower 2 to 3 vertebrae here, very sensitive. I'm going to see what we can do to help influence this and see about doing what's called light graded mobilization. It's a hands-on technique where we do an internal joint massage. See if we can't change that irritation in that area. How is the pressure right now?
Fine.
Any bother right now?
Nope.
I'm applying very gentle pressure on this area. Just getting pressure on and off. This is called graded mobilizations, like I mentioned. It's a great approach to find out what we can do to influence and improve flexibility in that spinal area. When I'm doing this technique, I'm stimulating nerves in that region to help calm that area down and also work to increase flexibility in the lower back. That may change symptoms down the leg. He's got a number of things going on. We're hoping that this focused treatment here might help him to stand, walk, and move a little bit more comfortably after this. I'm applying a little bit more pressure now. Are you feeling that?
Mm-hmm.
What's that seem like now?
Like you're applying pressure?
Pain?
That's it.
Pain?
No pain.
Okay, so not painful like it was before.
Nope.
At this point. So I'm feeling that lessen up. He might even be seeing me apply a little bit more pressure comfortably, but I'm just kind of following his lead, coaxing his body into more relaxation. I'm going to have you come on up to sitting, then to standing. We'll see what your response is. Just start by sitting, first of all. There's a number of things going on. That's one aspect of it, and we're going to assess what his response is. What's your first response to sitting? Just what do you notice?
No, the other side hurts, that side doesn't.
Okay.
I think this side's pretty good.
Come to standing, please.
And there's all the pain again. Got one right here on both sides.
I'll maybe take a walk to the doorway and back. What's it like to put weight through that left leg now? And walk back and forth again.
Is he shuffling or is he just walking normal?
I think some of that is the sound of his pants that are a little
Okay.
long.
Yeah. So I'm trying to hold him up. Walking seems better.
So he doesn't look like he's limping as much or favoring it.
That's what I notice. So I like that response, right? Now think about it, just some things to kind of have his spine, have his tissues talk to me, like, hey, what's aggravating? So we kind of knew what areas to focus on. Did some great mobilizations. We might take a look at some movements now. If you don't mind, I'm gonna have you bend forward once again, see what that's like. And come back up. Compared to before, what was that like?
Still hurts.
Backward bending, let's see what that's like.
That one's actually pretty good.
That's huge.
That one doesn't hurt as much.
That's huge, right? So I am doing the happy dance. This is a terrific outcome for a couple of reasons. Number one, we identified a number of things that we can intervene with. We can create more flexibility in those spinal vertebrae. We can help increase flexibility in the hips. We can help calm that nervous system down with a number of different techniques. And from a simple joint mobilization technique, he was able to walk better with less limping through that left leg. Forward bending is a little bit better. This backward bending is massively better. Anytime we can improve backward bending to the extent that we just saw here, that's a really good outcome because it speaks well to two things. Number one, his condition could change, and number two, that will really be valuable for him to pursue that process so that standing upright is easier. Right? So if you think about it, spinal vertebrae have the capacity to forward bend and then backward bend. Then when you come to upright standing, you're not jamming up against stiffness and backward bending. If I don't have much here, every time I stand up, I'm at end range. So if I don't have a lot of backward bending, it's as if I had normal bending, I was always at the end range. Does that make sense? Because you need to get your spinal vertebrae to stack up in that position. So it's a phenomenal outcome. I appreciate you donating your body to 5-Minute Miracle tonight. So that's a really good outcome. So thank you. So there's maybe a number of questions related to that. There's a lot more to that puzzle that needs to be sorted through, and I'm gonna look to kind of answer some of these questions. So I like this movement is much more smooth, and I like that, right? So is that all he's gonna need for treatment? Obviously not. His system is like that his body's been like that for 13 years. His body wants to pull back into some of the old patterns, but appropriate hands-on care would be really useful for him to create more ease of movement, right? So if he gets out up on the table and we just make his parts feel nice, that's awesome. Chances are his body wants to pull back into old patterns, so what we need to do is we need to teach him how to start to keep that flexibility with some repeated mobility on a regular basis. So there's some muscle re-education and flexibility things that we'd want to buttress this with and teach him so that he can start to manage this a little bit on his own, maybe once, twice, maybe even 3 times a day. So kind of flexibility things to keep that going. We're going to want to take a look at some of those other areas too. In addition, as his sensitivity and flexibility improve, we're going to want to help strengthen his muscles in that newfound range so he's able to get more muscle protection around that area. And then eventually we can start to work with some of those postural stiffnesses and things that are in his hips so he can bend and move without kind of straining his back. Eventually we want to get him to a point where he's got a nice concise package of some flexibility and pain relief exercises and some strengthening exercises. Strengthening exercises he might just do a couple times a week, but the flexibility and pain relief exercise he might do 2-3 times a day, maybe even during his work day. Right? So it's not just, hey, show up and plop up on the table and let's do some stuff to you, but it's how can we get you to stand, move, walk, hold yourself in a more upright posture, and be able to build some strength for the things that you want to be able to do. And that's the goal of intervention, right? So we know we can relieve pain in a number of ways. He could lay on the table and probably get a really good massage, get some pain relief. But that's not going to help him move better in his work or the things he likes to do, right? We can mobilize joints, stretch him out. That's going to help him, but long term, he needs to learn how to help do that, if you will, for himself. Does that make sense?
So you're gonna give him the exercises to do?
Absolutely.
Yeah.
Yeah, so whatever he needs to get to the next level of recovery, like I'm not, like we do exercise, we do hands-on work, we do muscle massage work, we do dry needling, we do all that sort of stuff, right? But it's in the context of trying to help him get to the next level of ability.
So you better,
What's that?
you better? You think, right now, you, even though,
Sitting right now is a little better.
Mhm.
But like you said, it's gonna take more than just.
Yeah,
yeah, oh yeah.
absolutely. So, we, like I do a quick summary of when's a good time to consult the doctor of physical therapy when pain interferes with your ability to sleep through the night. If you can't get good restorative sleep, that's not good for cognition, it's not good for mood, it's not good for tissue healing. There's stages of sleep that help improve your psychological and physical recovery. Pain keeps you from thoughtlessly and fearlessly participating in your housework, gardening, travel, or participating in your favorite exercise or sports, including work. If you're fearful of losing your independence and want your family or others to stop worrying about you, that's another good time to consult. Keep massaging, slathering pain ointments, or getting repeat treatments without actually making improvements in your self-control. That's a good time to get intervention so that you're not just spinning your wheels. You're interested in minimizing drugs, injections, and surgeries. I want to eventually learn how to self-manage. We talked about that at later stages so that he can be more reliant on himself. The thing that makes me excited about driving to work every day is having modern physical therapy intervention is effective because we can provide pain relief through joint mobilization. That's the technique that we used with him. More ambitious stuff might be cracking the back. We don't necessarily need to do that, but we can do that. That's a nice way to provide some pain relief. That provides a window of opportunity for things to move better so that we can get some of that exercise prescription going. We can provide massage work. We use instrumented soft tissue mobilization, which is a fancy word for tools to get deep massage work to muscles that are kind of stubborn and have those painful knots. We develop an exercise prescription based on an individual's need to help speed recovery for the flexibility and strength development. We want to develop a strength program so folks can get back to full strength of their muscles, of their legs, torso, to do the things that they want to do. Some people I just want to maintain my independence. Other people it's gardening. You, it's golding, or what do you call it?
Gold panning, metal detector.
Gold padding, metal detecting, after he works as an HVAC, right? So, and we utilize dry needling, which is the use of acupuncture needles to help provide pain relief. That might work really well for some of his really hot segments that are really irritated, can help calm down irritation down. And we can provide that as well. So, modern-based doctor of physical therapy is a provider of choice for non-prescription, non-drug care to help individuals get to their goals of increased function. We talked a little bit about the 4 phases of plan of care. This is a graph illustration. The first phase is to relieve pain and inflammation. Second stage is to correct the root cause of the problems, including balance and of the joints and muscles. Third stage is to strengthen within that newfound range, and final stage is to preserve your improvement with an ongoing self-management program. Everybody's sequence to get to that is a bit different, but at the end, we want people to be a bit more self-reliant. We've got a list of some testimonials of some folks that we've seen, and we do one-on-one hands-on treatment here, and we individualize exercise programs to strengthen back, legs, and spine. We can offer supplementation and lifestyle recommendations. So, from here, I'm happy to answer some questions, but next step for those that you want to move forward to get a look at how this might impact for your situation, we're happy to offer for folks who come here what's called a complimentary discovery visit, and that's where you'll meet with one of the doctors of physical therapy, go through a similar process, maybe a bit more in depth with questioning and a little more paperwork that we did with Justin to go through an assessment and come up with a plan of what a solution looks like in your case. Your packet of information has a piece of paper there. You can simply fill that out, and then when you come, we can have an understanding if you want to use your insurance of what it would look like for cost for you for plan of care, and one of the ladies can help get you on schedule. We have a number of appointment slots, Monday, Tuesday, Wednesday, Thursday, Friday of this week and next week. You just simply grab one of these slots here, and then go up and one of the ladies will help get you set up for that. Referral isn't typically needed. If it's needed for your particular insurance company, we can help obtain that. Oftentimes questions are, you guys are really attentive, so answering questions that often comes up. We individualize treatment plans of care, so there's no like, hey, what's the average number of sessions? We don't know until we look at your situation. Questions?
And whether or not you're exercising, that facilitates a quicker remedy.
Do you have a list of insurances that you accept or work with, or is it kind of on a case-by-case basis?
It's a case-by-case basis. A lot of the big insurance companies, they have lots. They might have hundreds of different policies that cover differently. So it's generally just best just to kind of give them the insurance information, and we have a team that helps with insurance verification to help identify what that is ahead of time.
But when you did my shoulder, I had no insurance, I had no bills. My insurance paid it all. I didn't get nobody told me to come out here. So now if you're gonna help me with walking, standing straighter, I should be okay with the insurance, right? You think?
Assuming nothing changed between then and now, it's really good tea, by the way. Yeah, assuming nothing else changed. Yeah.
So what we do is we take your insurance information and we do a complimentary insurance verification check, just so that when you come for that free discovery visit, you know what the cost breakdown would be. So no hidden surprises, we'll have that information for you.
We go through what's causing your pain and trouble, right? What can you expect to get back to? What kind of approaches we use, what that looks like for your time and money, depending upon your situation, and then you can decide how you want to move forward.
If you're already seeing a physical therapist, how do you change if you're going to change to have a different exam by someone else? Does it hurt the other therapist?
You have to be discharged if
Well,
you're currently under someone else's care. I think most insurances require, not for that first visit though,
Okay,
Mm-hmm.
because that's not through insurance, that's
Free.
Ultimately, there's a couple things, right? Like if you're using insurance-based services for the same sort of treatment, they don't like people splitting that.
mm-hmm.
But you can always you have choices as to where you go, right? So we can investigate that further.
If you're having pain and when you're walking, if you put your hand here and it doesn't, is that a good idea to walk that way, or is it best not to do that?
Depending on what part of town you're walking. I'm just kidding.
Yeah.
Wise guy. Ideally, you want to be able to move freely, comfortably, without having to.
But does it cause any more harm? Are you accentuating the problem you have by walking that way?
Probably not.
Okay.
But you don't wanna walk like that all the time.
Oh, no, it's not all the time, but it's when I'm working the gift shop.
How does that walk that way, talk that way?
Right. Super. So, who's here yet? Is Megan's
Yeah. Yep. So on your clipboards, there should be, if you're interested in the appointment, there should be like a little quick form for your name.
Shoot.
Okay. Let me get you some clean ones. Sorry, I didn't do the earlier one today, so I might have to get you clean forms there. My bad.
I have one of those.
You have one? There you
Yeah, I have
are.
one of those.
Oh, did you fill it out already?
Yeah, I did.
Oh, thank goodness.
Yeah,
Ay,
sorry.
ay, ay.
I
Okay,
didn't
and
know
then
I
did you
should.
guys have your tickets on there?
No.
The tickets, okay.
Tickets.
I wanted to also let you know
Speeding
that,
tickets.
I don't need that.
I enjoy public speaking. I'm speaking recently to the Quilters Guild in Appleton, church chat ladies, service organizations. So if you're looking for a wide range of topics, sleep and health, exercise and wellness, back pain, knee pain. I put on a presentation of how to become a really good healthcare consumer at the senior center a few weeks back. That was not well attended, but that's
It was
okay.
at a bad time.
Maybe. I don't
Or
know.
individualized
Well, for me it was.
attention, right?
Maybe. I think I gotta sex that title up a little bit. Like how to not let healthcare system kill you or something. Maybe more people.
Do you go as far as Wild Rose?
I would. Yeah.
Because our volunteer group I volunteer there and we, at the hospital, and sometimes they're looking for speakers.
Here's the thing is that
They have people.
it's
up there,
reason I'm
too.
happy. But yeah, I think it's important for people to gain more education. I got to schedule with them again. I got to pick at Senior Center. I'm hoping to go to AMRO, and yeah, I'm happy to do something like
So
that. Just reach out to me at to the office call and reach out.
is this for us here now?
That's for you. That's called the golden ticket. It's like a Willy Wonka golden ticket.
So then when I come in, then I give you this ticket, or do I give it to my sister? I mean, this is gonna be my free checkout, is that it?
Yes, exactly right. And I think for you, you can hand it to your sister too.
Well,
She ain't
she's
some
got
prize
a
along.
bullhead.
Well-
She's the dominant twin.